Hello students, this is a CPR1 biochemistry lecture called Clotting Cascade. Here's my contact information. My name is Jeff. Let's get started. At the Osmosis online learning resources, I've created Dr. Staudiger's Osmosis Coagulation Cascade playlist. If you click on this link, the playlist will be revealed to you. There's 7 topics, short videos that you can use to solidify your knowledge regarding the coagulation cascade. This is a picture of scanning electron microscopy of a coronary artery thrombus taken from a patient who had a heart attack. The fibrin fibers are in brown, platelet aggregates are in gray, red blood cells are in red, and leukocytes are in green. I think this picture, first of all, is beautiful, but it illustrates the overall process of what we're attempting to build using our biochemistry. And one should take a moment to appreciate the beauty and wonderment of this process. Highly complex, highly regulated, an important drug target as well. The following is a short video entitled Platelet Activation and Factors for Clot Formation that I believe captures the essence of the biochemistry of what we are learning today.
In a first step towards clot formation, platelets are recruited to the site of vessel injury by now exposed molecules of the vessel wall, such as collagen and von Willebrand factor. This factor mediates the linking of platelets to collagen via a specific receptor in the platelet membrane. The resulting change of shape of the platelet from its resting state into the dendritic form indicates activation. The activated platelet in turn releases prothrombotic molecules such as adenosine diphosphate, ADP. By binding to its receptors, ADP induces aggregation. And recruits further platelets to the site. Thromboxane is another important mediator of platelet activation and aggregation. Under its influence, the platelets cross-link with each other. These interlocking mechanisms cause platelet activation to snowball. The clot grows rapidly. Activated platelets also trigger the coagulation cascade and thus the formation of thrombin. Thrombin, in turn, stimulates platelet activation even further, a continuous feedback loop. Additionally, thrombin induces the formation of fibrin for the mesh stabilizing the clot. The self-reinforcing process of platelet activation, crucial in the formation of blood clots, is an obvious therapeutic target in conditions caused by inappropriately triggered blood coagulation.
That video captures the overall gestalt of what we're trying to learn today. I'd now like to present a typical test question in a practice format for you to see what you can expect in the upcoming exam. A 68-year-old man on warfarin therapy for 5 months following a series of small strokes has now fallen and fractured his left hip. 48 hours prior to surgery, his warfarin is discontinued and prothrombin times are measured until coagulation is in the normal range. The 48-hour interval between discontinuation of warfarin therapy and establishing a normal PT is due to which of the following? I'd like to highlight the important and salient features of this test question. 2 days prior to surgery, clinicians withdrew his warfarin. So the question is why? Is it because of the half-life of circulating coagulation factors due to the slow absorption of warfarin? Or the time required for activation of the coagulation pathway? Or the time required for full expression of factors 2, 7, 9, and 10 genes? Or the time required for reoxidation of vitamin K? The correct answer is time required for full expression of the factors 2, 7, 9, and 10. By the end of this lecture, you'll be able to understand that warfarin decreases the amount of active vitamin K. Moreover, you'll understand the nuances of vitamin K being required by gamma-glutamyl carboxylase and that warfarin inhibits epoxide hydrolase. Turns out gamma-glutamyl carboxylase enzyme catalyzes an essential post-translational modification step in the biosynthesis of factors 2, 7, 9, 10, protein C, and protein S. All of these factors are involved in the coagulation sequence and its control, with 2, 7, 9, and 10 being pro-coagulation and protein C and S being anti-coagulation factors. When a patient is first given warfarin, its full effect is not seen for about 48 hours. And that's because the previously activated factors in blood must decline, and resynthesis of these factors must begin before warfarin will interfere. When warfarin is withdrawn, it takes time for full resynthesis of these factors before coagulation will achieve normal levels. It's critical that you remember factors 2, 7, 9, and 10, protein C, and protein S. Specifically in this regard, the half-lives of the vitamin K dependent factors are shown here. Factor 2, 60 hours. Factor 9, 24 hours. Factor 10, 40 to 60 hours. That's a fairly long time. Degradation of these factors thus become rate limiting upon withdrawal of warfarin therapy. It's also worth noting here that factors 2, 7, 9, and 10 promote clot formation, whereas protein C and S physically interact with each other to drive an anticoagulant function to help our body break down the clot. This brings us to our learning objectives for this lecture. We're going to compare and contrast the physiologic sequence of steps in the intrinsic and extrinsic pathways of secondary hemostasis. We're going to compare and contrast hemostasis, clot, hemostatic plug, coagulation, and coagulation cascade. We're going to compare and contrast the physiologic roles of fibrinogen, thrombin, and fibrin. We're going to dissect the role of vitamin K in the clotting cascade. And we're going to establish the molecular mechanism of how the drug warfarin impacts the clotting cascade. Finally, we'll identify the precise relationship between Factor VIII and hemophilia. Learning Objective 1. Intrinsic versus extrinsic pathway activation. The intrinsic pathway is activated by trauma inside the vascular system through platelet interaction with exposed endothelium, chemicals, or collagen. The intrinsic pathway is slower than the extrinsic pathway and involves factors 12, 11, 9, and 8. You can see a diagram of the intrinsic pathway here. The extrinsic pathway is activated by external trauma to the system, such as when blood escapes the vascular system. It's much quicker than the intrinsic pathway because it only involves a single factor, Factor VII. Let's take a little bit of a deeper dive into what happens following the activation of the extrinsic and intrinsic pathways. It's worth mentioning here that many of these clotting factors are in fact serine proteases to activate each other in a cascade as well as deactivate in some cases. In other words, this is a highly regulated process. More specifically, the following clotting factors are serine proteases listed here. The following clotting factors are not serine proteases listed here. To summarize, the intrinsic pathway is activated through exposed endothelial collagen, and the extrinsic pathway is activated through tissue factor release by endothelial cells after external damage. Here are two figures depicting the extrinsic and intrinsic pathway, regardless of the mode of activation, whether extrinsic or intrinsic. In this figure on the left, you can see formation of the tenase complex at the cell membrane. The tenase complex consists of activated factors denoted by the small letter A. Wherever you see the small letter A, that means activated. In both cases, you see a coalescence factors to form this tenase complex in both the extrinsic and intrinsic pathways. They associate with calcium, denoted by these small white dots, and phosphatidylserine at the membrane. The very interesting and specific manner in which clotting factors interface with these calcium molecules will be discussed later in this lecture, but it has a lot to do with the mechanism of action of warfarin. To move into the common pathway, there is a formation of the prothrombinase complex. The prothrombinase complex then drives formation through thrombin of the fibrin clot. And if you click on this link, a very interesting and useful web page that describes this process in excruciating detail will be revealed to you. This is an additional resource for your understanding of the clotting cascade. Learning Objective 2. In primary hemostasis, platelets in the blood aggregate at the injury site and form a platelet plug to block the hole. Whereas in secondary hemostasis, the platelet plug is further reinforced by a fibrin mesh produced through this cascade of proteolysis. The key difference between the primary and secondary hemostasis is that primary hemostasis makes a weak platelet plug, while secondary hemostasis makes it strong by generating a fibrin mesh upon it. Here is a useful table of primary versus secondary hemostasis to include the process, goal, components involved, and the duration. Learning Objective 3. Production of thrombin is self-activating in that additional prothrombin is converted to thrombin. Thrombin also activates platelets and converts fibrinogen to fibrin. Also converts several factors to include factor V, VIII, and 13 to the activated form. Hence, thrombin is a central regulator of secondary hemostasis. While thrombin is regulating secondary hemostasis in a central fashion, the production of plasmin from plasminogen regulates fibrin degradation. Through these regulated processes, our biochemistry achieves an exquisite balance. Learning Objective 4. Let's talk about oral anticoagulants. There are two types of oral agents, hydroxycoumarins and indanidiones. All of these compounds have a common mechanism of action of vitamin K inhibition. Let's dig a little deeper into vitamin K and the coagulation cascade. Vitamin K is reduced from the quinone or the inactive form to the quinol or the active form in liver. There's two steps for the activation of vitamin K. The first step occurs through vitamin K 2,3 epoxide reductase and uses reduced NADH as a cofactor to convert the 2,3 epoxide to the quinone form. In the second step, the quinone reductase reduces the quinone form to the active quinol form. The carboxylase activity is coupled to epoxidase activity, and vitamin K is oxidized simultaneously to the 2,3 epoxide. Subsequently, the 2,3 epoxide is converted to the active form by two successive reductions. I'll show you that diagrammatically here. In this diagram depicting the vitamin K cycle, you'll notice the vitamin K 2,3 epoxide reductase enzyme and the quinone reductase enzyme are coupled. Vitamin K is cycled through this, and the quinol form is used as a substrate for gamma-glutamyl carboxylation. In other words, it takes inactive factors, adds this special carboxyl group to activate factors 2, 7, 9, 10, protein S, and protein C. We'll look a little bit deeper into the function of gamma-glutamyl carboxylation of these factors. The drug warfarin targets vitamin K-dependent epoxide reductase. The vitamin K cycle produces this interesting carboxylation of glutamic acid on proteins 2, 7, 9, 10, protein S, and protein C. So inhibition of vitamin K epoxide reductase reduces the carboxylation of glutamic acid residues in these factors. And you can see that in this diagram here. This glutamate residue is present in factors 2, 7, 9, 10, protein S, and C. And it turns out the hydroquinone form of vitamin K, together with oxygen and CO2 through the actions of vitamin K-dependent carboxylase, produces a modified glutamate residue called gamma-carboxyglutamate, and these residues are contained within these clotting factors. Warfarin targets vitamin K epoxide reductase to inhibit its activity. Thus, this reaction will slow down, and as these factors degrade and are not replaced, blood clotting is inhibited. To summarize, the formation of the gamma-carboxyglutamate residues in these factors enables them to coalesce with calcium and form the tenase complex. Warfarin targets the vitamin K-dependent epoxide reductase enzyme here, such that as these proteins degrade and this reaction slows down and eventually is diminished greatly, this prevents the formation of the tenase complex and coalescence with calcium, and blood clotting is thereby inhibited. I'd now like to summarize the interactions between warfarin and the vitamin K cycle in our bodies. Blood clots are formed through a series of vitamin K dependent reactions in liver. Warfarin prevents harmful blood clots from forming. Warfarin works by decreasing the activity of vitamin K dependent epoxide reductase, thereby lengthening the time it takes for a clot to form. Vitamin K is a cofactor in synthesizing factors 2, also known as prothrombin, 7, 9, and 10, protein S and C. Vitamin K sensitive step involves the formation of a unique amino acid, gamma carboxyglutamate, in specific coagulation cascade factors in liver. 10 of these carboxyglutamate residues chelate calcium in vivo. This allows for the binding of 4 vitamin K dependent cofactors to bind to phospholipid membranes during activation of the coagulation cascade to form the tenase complex. Elevated prothrombin time and mucosal bleeding in patients that have been treated with warfarin a little too aggressively. Initial treatment is parenteral vitamin K and daily oral vitamin K. There are numerous drug interactions with warfarin. Orally ingested warfarin is virtually completely absorbed, and peak plasma concentrations occur about 3 hours after the drug is administered. Only free warfarin is pharmacologically active. S-warfarin is more highly bound to albumin than R-warfarin. The S form is about 5 times more potent as a blood anticoagulant than R-warfarin. Therefore, and this is important, drugs that alter the level of free warfarin by competing for binding to albumin or by inhibiting or inducing the drug's metabolism may influence the anticoagulant effect. Here's a list of drugs that potentiate the action of warfarin and those that antagonize the actions of warfarin. I've mentioned before, but I'd like to stress here that protein C and protein S have anticoagulant action. Both of these proteins get together to play an important role in regulating anticoagulation. Protein C and S physically interact to proteolytically inactivate factor V and factor VIII. Patients with a genetic protein C deficiency exhibit a large increase in the risk of venous thrombosis. Again, protein C and protein S physically interact to degrade factor V and factor VIII to limit thrombin formation. By simultaneously activating procoagulation factors and anticoagulation factors, our bodies are able to keep this biochemistry in balance. Some specific counseling points might include the fact that there are many drug interactions with warfarin, so patients should check with the doctor and their pharmacist before taking any new meds while taking warfarin. Routine INRs must be done while your patients are on warfarin therapy. Watch your patients for signs and symptoms of bleeding. Side effects of warfarin include stomach pain, palpitations, fever, wheezing, nausea, vomiting, and diarrhea. Patients taking warfarin need to carry an ID card. And patients need to be counseled to be careful of their diet. Be consistent with the intake of vitamin K-rich foods, such as green leafy vegetables like spinach. Let's talk about hemophilia A. It's also called Factor VIII deficiency or classic hemophilia A. It's caused by missing or defective Factor VIII, usually passed down from parents to children. However, about a third of the cases are caused by spontaneous mutation. Hemophilia A occurs in approximately 1 in 5,000 live births. Around 20,000 people have hemophilia in the United States. All races and ethnic groups are affected. Hemophilia A is 4 times as common as hemophilia B. More than half of the patients with the A form have the severe form of hemophilia. Hemophilia B is also called Factor IX deficiency or Christmas disease. It's worth noting here that in the face of deficient or absent Factor VIII, the conversion of Factor X to the active form is disrupted. And you can see that here as well. As a matter of fact, assaying for the presence of Factor Xa is the diagnostic tool for hemophilia A. Student doctors, please note I've added a series of practice questions and a high-yield worksheet for you to work your way through, especially as you head towards board exams. Additional information can be gleaned from the practice questions as well as the high-yield worksheet. May peace be with you.